Hello everyone, my name is Vijay Kunadian. I'm Professor of Interventional Cardiology from Newcastle University. I'm joined by Professor Raj Kharbanda from Oxford Hospitals and also by Dr Richard Jabbour from Southampton General Hospital. The purpose of this session is to discuss the role of cerebral embolic protection devices to prevent post-procedural stroke events during TAVI procedures. So we clearly have expert colleagues with me right now to discuss this very, very important topic. And of course, we've made major progress in the management of cardiovascular disease, particularly in the ever-growing aging population that we deal with every day. So we'll get started straight off. So stroke is a huge issue, and it's absolutely devastating for patients, particularly when it happens after we've done a procedure, whether it's coronary intervention or TAVI procedures. So take us through the incidence of stroke in these populations, and what are the studies that we have so far in this particular topic to see if we can prevent these events happening.
Yeah, absolutely. So as you mentioned, TAVI has pretty much revolutionised the treatment of aortic stenosis, but one of the most devastating complications is stroke. And there is some large registry data, specifically from America, that was published in JAMA in 2019 involving over 100,000 patients. And they found that the incidence of stroke at 30 days was 2.3%. The majority of strokes occurred, I think 70% within 72 hours and around half within 24 hours. And importantly, they found that stroke was associated with an increase in mortality at 30 days with a hazard ratio of 6.1. And something that's interesting is that over time, the incidence of stroke did not decrease. It stayed relatively constant between 2 and 2.5%. So there really is an unmet need to try and mitigate the risk of stroke, which sort of brought around the whole concept about cerebral embolic protection. And the device that has been most extensively studied is the Sentinel device. It's a device that essentially protects 75% of the cerebral circulation by effectively covering and protecting the right brachiocephalic artery and the left common carotid artery. The remaining artery that is not protected is the left vertebral artery. And there have been lots of registry studies and a specific randomized trial that shows some signals that it may reduce stroke, and hence that's why the Protected Tavi study was performed.
Yeah, so I just want to focus a couple of minutes on what sort of contents is actually in the brain. So I had a feel for in an autopsy aortic valve, the disease valve is so hard, it's like a rock. So if you just want to go through, is it the rock that we are breaking that's ending up? And also these patients have a lot of atheroma hanging in when you do a TOE and things like that. You see these dangling. So do we have a feel for what is the main content that actually goes into the brain, and all of them perhaps?
Yeah. So in the Sentinel IDE trial, which randomised 363 patients, they found debris in over 99%, well in 99%, so practically everyone had debris. And actually it ranged from small calcific nodules to, as you mentioned, to atheromatous material to even thrombus. So it actually it captures a wide range of debris in the baskets actually.
Yeah. So this sort of studying, capturing these, we won't be able to capture everything, I suppose, because of the nature of what we do. And we've had a number of registry studies, and I'm aware of some of the registry studies that come from the United States, and they didn't really, I think it's an STS registry or something that was presented a few years ago. Yeah. And then we have, I think to date, we have large studies that are ongoing. So take us through the findings from the registry studies and the latest randomized clinical trial that's come from across the Atlantic.
Yeah, so there's quite a lot of registry data available, and depending on what analysis you do, there are some studies that say that it may reduce stroke in propensity matching, and it may even reduce mortality as well. but there's no clear signals. And specifically from that randomized study, the Sentinel IDE trial, where they found in a post hoc analysis that there was a reduction in stroke, but it wasn't the primary endpoint and it was underpowered. That was the whole kind of paradigm behind performing a dedicated, adequately powered study to detect all-cause stroke. The Protected Tavi study, it was powered for a control stroke rate of 4% with a 50% reduction with the device, so 2%, with 90% power, and the final kind of study group that they suggested was 3,000 patients with a maximum of up to 6,000. Patients were randomized 1-to-1, and there was a interim analysis once 70% of the patients had been enrolled, and it had some very interesting findings. First of all, if we go back to the study flow, it was randomized 1-to-1, so there were 1,500 patients, give or take one person in each group. The vast majority of patients were followed up, so 99% completed enrolment. And notably, in the treatment arm, 5.5% of patients, they were unable to insert the device, which I think is very important to mention. So about roughly 95% of patients, the device was feasible to insert. The reasons for not being able to insert the device were things like tortuosity, spasm. Those were the main issues with inserting the device, but as I mentioned, the vast majority did have the device inserted. Now, regarding the primary endpoint, which was all-cause stroke at 72 hours or discharge, whichever one came first, it didn't meet its primary endpoint, so the trial overall was neutral or negative. But if you looked at the primary endpoint and analysed it, there was a non-significant 21% relative reduction in stroke in the treatment arm. So that is, potentially an inciting signal. And then they looked at the pre-specified secondary endpoint, which was disabling stroke, and they did find a significant reduction with a p-value of 0.02 and a roughly a 60% relative reduction. So again, some exciting signals. But if you go back to the power of the study, it was powered for a control rate of stroke at 4%. And if we talk about the registry data of that 100,000 patient study, the incidence of stroke was 2.3%. So it indicates that potentially that study was slightly underpowered, which brings us on to the UK study, which is ongoing at the moment, the BHF Protect, which I feel will provide a definitive answer as to the efficacy of this device. Yeah,
we are going to be discussing a lot more in detail about the BHF Protect Tavi trial. But I just want to have a feel for, of course, in the Protect Tavi study, they used the Sentinel. But are there any other devices that has been evaluated in this setting?
So there are a few, and they've used surrogate endpoints. So there's the TriGuard device, which is femoral access, and that has used a surrogate endpoint for evaluation, and that was neutral for the imaging endpoint. But it was a safety trial. It was a safety and feasibility trial. So we don't have any other devices that have been explored with such a large number of patients. And there are a range of other devices being developed, but all of those are at a very early stage of assessment in terms of safety and feasibility, and largely using imaging endpoints as a surrogate for efficacy.
So obviously you touched upon, was it 94% of cases they were able to deliver the device, and of course we're dealing with really older individuals in their 80s, and tortuosity we're all used to when we're doing the coronary procedure, for example, is a challenge indeed. So, but it's not doable. We're capable of handling tortuosity, but you have to be careful in these patients. Absolutely. And what are the potential? You have done a lot of cases as part of the trial in Southampton. How to navigate this challenge? Do you give up if it doesn't go away, or are there any tips and tricks?
So we, as mentioned, we're part of the BHF study, and we implant quite a few of them as part of the trial. And we find that using a workhorse coronary wire up front, such as a cyan blue wire perhaps, enables us to navigate that tortuosity, as you say. I think obviously talking to the patient, it's just like coronaries, talking to the patient, explaining what you're doing, making the patient feel at ease does obviously mitigate spasm as well. But we find that, you know, based on various anatomy, the cyan blue in the majority of times enables us to implant the device. And sometimes if there's some excessive tortuosity in the arch, we may use an extra support wire, but still a kind of cyan blue extra support wire, for example. Yeah. So there are various tips and tricks that you can use to implant the device.
Yeah, I think it's about pre-procedure planning. I think as you know, the CT is so crucial to TAVI planning. But I think as operators, many cardiologists may not be familiar or necessarily engage with looking at the origin of the head and neck vessels, the anatomy. So there are variations in where the origin of the left carotid is. Is it truly bovine? Is it off the brachiocephalic trunk? And how far it is? And going into the case, understanding the anatomy is crucial. It's not just right radial, you know, you can deploy the device via the right ulnar or the brachiocephalic artery, the brachial artery if you had to. And I think those are things that we, you know, as experience. So in terms of learning curve, it's not a difficult device to deploy technically, but I think there is some learning about the anatomy and understanding which anatomies are perhaps more complex.
I'm a massive person with pre-planning, so I think, Raj, you really emphasize the importance of planning, anticipating any potential challenges, use all your investigation modalities that you have already before you commence the case.
And I think it's something, as you know, as cardiologists, that sometimes, you know, we don't, not everybody is familiar with looking at the CT in detail and getting all of that information out before you go into the case. So I think as a learning point, you know, learn to look at the anatomy. It's really a useful step, I think.
Yeah, and I would say that, you know, during our MDTs in Southampton, when a patient is, you know, potentially recruited for the trial, we do look in detail at the CT. So, you know, just to emphasise the point, it can be done in an MTT basis as well.
So I think, Richard, you provided a fantastic background. There is definitely an unmet need. We have to prevent these strokes somehow or the other, whether you pay extra attention to how you're doing the case, which I am a strong believer in, or the additional devices. And so far we have registry studies, we have randomized clinical trials, which still haven't quite provided with the level of evidence that we need to change the guidelines and to implement that into daily clinical practice, which is where you come along. I know the feeling of a chief investigator running a big trial. And so you are leading on the British Heart Foundation Protect Tavi trial. So take us through that, Raj.
Yeah, so that was conceived at a similar time to Protected Tavi, probably. And the background and our assumptions were slightly different. So we assumed a 3% stroke rate in the control group. We calculated a 33% relative risk reduction, so from 3% down to 2%. So a more conservative effect size with a lower stroke rate. And that means we need to randomise 7,730 patients in all. So we are, and that trial is underway. It's undertaken across 30 of the UK TAVI centres. It's a UK-based trial. And it's all-comer in that the exclusion criteria are minimal. And what we're really looking for is as a workhorse device in a clinical setting with clinicians who are comfortable to randomise the patient. Does the device reduce stroke? In terms of the endpoint, it is all-cause stroke at 72 hours or discharge, whichever is sooner. And the way that we are assessing stroke is with a validated questionnaire which screens patients, and then a formal stroke assessment if they flag up on that. So it's a different approach to Protected Tavi, but it's more pragmatic because of the large size of the trial. we hope certainly we don't miss any large strokes. I mean, obviously there are, stroke is a spectrum, and I think it's one of the things about the cognitive decline and some of these less specific neurological events that present in non-classical ways. But the way that we've set it up, we at least have a formal assessment for any concerning neurology that develops.
Yeah. For the formal assessment, are neurologists coming and seeing these patients, or just led by cardiologists?
No, we've recommend. So it's as you would do with a stroke team review. So if a patient has a peri-procedural stroke, the recommendation for the trial is that they have a formal stroke team review. So it's formalised in that there is a filter, but they should have a formal stroke review.
Yeah. So it's really fantastic that your exclusion criteria is very minimal, because in these old sort of population that we're dealing with, people would just say, well, I'm going to exclude this person if they've had multiple strokes or TIAs or frail patients. So it's these people that we're treating. There's no point in excluding them. We want to include them. So that's really fantastic. So
so it's exactly that funnel, isn't it, of the proportion of eligible patients and the number that are randomized. And often randomized trial groups don't necessarily represent the population, the wider population, and there's sort of selection. So we, as it's going at the moment, we've managed to recruit nearly 40% of the TAVIs across the centres. So it's a testament to the commitment of the TAVI community that they're willing to recruit these patients and enrol them into the trial, and about 3.5% of those are valve-in-valve procedures. So the complex cases aren't being excluded as such.
Yeah. So I wanted to come on the 40% inclusion rate. These cases are handled by all our interventional cardiologists who are expertise in recruiting to patient clinical trials, and they are the ones who are doing the study. So I would have expected more than 40%. Everybody should really be going into the trial. So I was just thinking, what percentage of these patients do you have actually patients say, I don't want to participate?
Yeah, so at the moment, the reasons for exclusion, about 20% of patients don't want to participate in the trial. And the other reasons for exclusion have been anatomy, unfavourable anatomy, and a small proportion because of resources. So, the vast majority, though, is the patient not wanting to participate in the trial.
Yeah. So that's interesting. Yeah. So the question, have you, the trial is going very well. Very rarely you see the actual recruitment curve is actually above the predicted rate. So everybody is doing a fantastic job despite the pandemic. So so you're participating in what is your experience?
Yeah, I would say probably between 10 to 20% of patients refuse. And it's exactly how you said. We discuss, we look at the CTs in our MDT. If we think it's favourable, we will, one of the research nurses, we have a very large research team of excellent nurses that would go and recruit the patients. And I would say we're doing quite well at the recruitment at Southampton. So we try to recruit as many patients as we can. It doesn't matter if it's a low risk or a high risk patient. We're really trying to do it as an all-comers study.
Yeah, the resources is a big challenge. Of course, particularly right now, a lot of the research team are being asked to manage clinical patients. So it's all of the practicalities of running a clinical trial. So, but overall, this trial is going very well. Is there anything else additional that you want to add with regards to the study? Are you looking for more sites, or what is?
No, at the moment it's limited to the UK, and all of the everybody's been invited, and we've got a good number of centres recruiting well. So we've got not only stroke, the secondary endpoints are stroke and mortality, and we've got a number of other endpoints, including an embedded cost-effectiveness analysis. So these devices do cost, but the consequences of stroke and disabling stroke are also expensive and cost and have healthcare resource implications. So there is an embedded cost effectiveness analysis focused on the NHS and the UK healthcare system. And I think that's an important point, that other healthcare systems have different costings and so it may work differently in different healthcare systems in terms of that aspect. So there's the clinical effectiveness and the cost effectiveness.
Yeah. Particularly for these patients, it's often the quality of life rather than and for their families.
Yeah, and exactly right. And so even what we would consider a non-disabling stroke, for example, somebody losing their speech, the current scoring systems for stroke don't weight that heavily, but for an elderly patient, that can make them lose their independence, and it could have much more disabling effects in terms of quality of life rather than the extent of stroke. And I think those things we're hoping to capture in our trial, because we're looking at 12-month follow-up, we're looking at healthcare resource utilisation, and we've got quality of life assessment. So, those, as you say, those things are really important for this population in terms of returning to independence and improving quality of life.
Yeah. Was there any other additional points that you want to add, Richard?
I think it's very, very important that we have that 1-year follow-up, because in the Protected Tavi study it was really a short-term follow-up. And I think if you look at the data that we have so far, the number needed to treat is relatively high, so about 125 for disabling stroke. So we really need to identify longer-term follow-up, if there's any cost-effectiveness of the device, etc., because the devices, they're not without cost, and specifically related to the NHS, we do need to really identify any potential cost-effectiveness.
Yeah, thank you. I think it's 20 years since Tavi was introduced. I remember being a registrar and performing our very first Tavi in Newcastle, and clearly we've transformed the way how we manage these patients who normally would never get the opportunity even to reach a cardiology ward, for example, they get managed by. So we have made such transformation in these precious older people with aortic stenosis. So, but of course it is our responsibility to ensure that we're able to perform this procedure with minimal procedure-related events, and that is why these trials are so important and constantly innovating to identify the best treatment. So it is an unmet need, and clearly we need to have further evidence to determine if actually cerebral protection device indeed reduces these devastating consequences of stroke and other associated neurological conditions. So we eagerly await the results of the Protect Tavi trial results, which I think we will have sooner than later, given the way that the trial is going at the moment. And again, I really want to congratulate the entire UK. First of all, I know it's such a hard work for leading this trial, and also to all of the investigators for their outstanding work. And of course, if we do find that this particular device is actually beneficial, then of course it will impact practice as well as adopted into the guidelines. So this is something that we really need to do for our patients, and hopefully we will have the results very soon. With that, I'd like to take the opportunity to thank Richard and Raj for your fantastic contribution to this session, and thank you all very much.